Thank you, Dr. Mahipal and Dr. Namrata, for the very kind words of introduction. I was hearing some echo from my laptop when I was giving the introduction to this webinar. Then I realized that a YouTube channel was running on the background, and I was able to hear my own voice. So now I have switched it off, and I think things are okay now. So I'll set the ball rolling by giving an overview on this topic and also lay down the roadmap for this webinar. Nothing financial in what I'm going to talk to you about today. Now, all of us cataract surgeons would like to hit the bullseye in our postoperative patients more often than not. The holy grail is plano 6/6 most of the time. And before I move further or go further, I would like to acknowledge the 4 guest editorials published in Journal of Cataract and Refractive Surgery over the last couple of years, which have basically redefined the way we think about IOL power calculation and has given a new direction, a new dimension to the entire process. And one of the contributors, Dr. Dr.Arup, is amongst us today. And other contributors also include big names: Warren Hill, Adi Abulafia, Lee Wang, and Jack Holliday. So what we have learned is IOL power calculation is not just a one-off event in the lifespan of a cataract patient. It is a process, it is a method that transcends the perioperative period. So there are issues in the preoperative period that we have to bother about, intraoperative incidents, and the postoperative phase. So preoperatively, before we embark on the biometry as such, it's important to examine and evaluate the patient properly, looking into the sources of vision loss and factors that could influence the accuracy of IOL calculations. We all know that the tear film is the strongest, most powerful refractive surface of the eye. And if there's any disturbance on the ocular surface, that is going to adversely impact the IOL power calculations. And we have none other than Dr. Marjan Farid, who will be talking to us on this topic and give us the Accura's preoperative algorithm and the US perspective on this topic. So patient counseling, as always, is a very important aspect, because it's not always that the patients look for the emmetropic target. You know, there are some of us believe in monovision, and then the refractive targeting would include a little bit of myopic correction, myopic target if you're thinking about some of these premium intraocular lenses, for example, the external depth of focus lenses, extended depth of focus lenses. And biometric measurements, we have learned that it should be done from multiple devices, 2 to 3. I, of course, don't advocate more number of devices, because, you know, there's a law of diminishing returns, and then, you know, you really do not get any enhancement by using multiple devices. Again, I would recommend the use of multiple IOL power calculations, and what exactly, how should we go about it? We'll wait to hear from Dr. Hanbor Pham and Dr. Dr.Arup after the talks are over. And after all these exercises over, we finally come down to selection of the right intraocular lens for the patient, which is going to be implanted in the patient's eye. Now, intraoperatively also, it has been a very standard. Almost all of us perform cataract surgery through a 2.4 millimeter temporal clear corneal incision. We make a rhexis, which is 5 millimeters in size, ensuring that there is a 0.75 to 1 millimeter overlap on the optic edge of the rhexis margin. In certain situations where the capsular bag support is compromised, for example, if we keep a lens in the sulcus, we may think about optic capture. If a lens is in the bag, we may think about a reverse optic capture or optic capture through the posterior rhexis. Or if there is no bag whatsoever, we may have to think about intrascleral haptic fixation, different types. So here we need to tinker with the intraocular lens power. And all these will be dealt with in the second part of our webinar in maybe next month. So we also have heard that intraoperative aberrometry has pros and cons, and it does well. There's a lot of publications that are coming on this topic. I am sure we'll be hearing about these things from Dow, as well as, you know, the guidance systems to orient toric intraocular lenses. Many surgeons use them. There are many surgeons who don't use them. They just use the manual slit lamp technique, slit beam from the slit lamp to orient the toric intraocular lenses. So post-operative period is the moment of truth. Moving beyond the anatomic outcome, we look at the refraction, and if there's an unwanted residual refractive error, the operating surgeon himself should be in a position to take care of it. Again, this discussion will be postponed to a subsequent date. So basically, how did the IOL power calculation all begin? We all know about Sir Harold Ridley, 29th November 1949, the first IOL was implanted, and on the same day was the genesis of the IOL power calculation and the refractive accuracy related matters. So anatomically, the cases did extremely well, but when the results were published in the BJO, the first audit cycle revealed highly myopic outcomes, minus 21 diopter and minus 15 diopter spherical equivalent. And in the second audit cycle also, the median postoperative refractive error was quite high, minus 2.25 diopter. So definitely, there was a long way to travel for us to refine the outcomes. If you look at the Royal College of Ophthalmologists cataract surgery guidelines, it says that 85% of the patients should be within 1 diopter of target refraction and 55% within 0.5 diopter. But I think we need to go beyond that. And at this stage, I'd like to refer to the presentation made by Dr. Warren Hill, the Charles D. Kelman lecture in the AO meeting in 2015, where he presented results from his database of more than 2.6 lakh eyes, which were worked out with Huygens formula, triple optimized for each surgeon. And the results are pretty interesting. The vast majority of the surgeons using this database could land only 70% of the eyes within a refractive accuracy of 0.5 diopter. And less than 1% of the surgeons were able to reach this level of accuracy in the 92% of the eyes. So there was a long way to go. And if these are all normalized, now the results were even worse when you dealt with eyes with extremes of axial length or post-refractive surgery eyes. There's another interesting, important publication that happened in the JCRS August 2016, soon after this presentation, which compared the visual outcome using 9 IOL power calculation formulas using optical biometry, and it revealed that the refractive correction, the refractive accuracy was between 75.1 to 80.6 using this multiple formulas. So definitely we are making progress from what we are achieving before that. Coming back to, again, Warren Hill, his Rayner Medal lecture presentation, where he presented his report results on Hill-Arbier formula. Only highly skilled surgeons were included in the study, and they operated on eyes with axial length mainly between 22.5 and 24.5 diopter, using a sophisticated optical biometer with careful scrutiny of the raw data. Results were really astounding. Now, there were 90% of the eyes these surgeons were able to land within the plus 0.5 diopter of the target refraction. So definitely we have come a long way. And then this is the latest publication that happened. I mean, I just want to trace out how the refractive outcomes, how the refractive accuracy evolved over a period of years. Can you hear me? Okay. So this was actually published by Savini et al. At the JCRS in January 2020. And here again, you see the results are pretty good. 84% to 90.67% of the patients were getting within a error of 0.5 diopter. And some of the formulas which did extremely well are basically very new formulas. You have the Kane formula, you have the T2, you have the EVO formula. And older formulas also did pretty well. Not as well as the newer formulas, but pretty well. So when you compare this study to the previous studies, the uniform theme was the refractive accuracy was getting better and better. So now what led on to this kind of situation? So we had newer instruments, more sophisticated instruments coming into the market, which were able to measure the dimensions in a much more accurate and precise manner, in addition to giving more number of biometric parameters. And the current formula, the older formulas have changed their version, they have been updated, and the new formulas came. And we have, again, understood the full significance of A constant optimization. And all these will be covered in the subsequent topics. There are a couple of the newer instruments will be discussed during the course of this presentation, and we have no financial interest. there were in 1999, we had the first optical biometer coming in, IOL Master 500. Then there was a series of similar standard optical biometers that came in. So the question arises, is there any one particular type of biometer superior to the rest of the biometers as far as the standard optical biometers? There are multiple publications in the literature, but what caught my attention was the one published in BJO, which compared the Aladdin and the Lenstar and found out that there was a high level of repeatability and agreement between these two devices. Many of us have gone into the swept source OCT-based optical biometer. And again, the question comes up, how does it compare with the older generation, the previous version of the optical biometer, the 500? So again, I refer to the BJO on the 2015 issue, and it said that there's a good agreement between the two devices. And of course, there are certain advantages of the IOL Master 700 over the IOL Master 500. So what I'd like to tell here is, the affluent countries or affluent practices can afford to go in for the sophisticated latest generation devices, which come with a cost. But the developing countries definitely still have to make do with the existing technology, the equipment that are available in the older technology. And we have lined up a series of talks based on how to get maximum output, maximum results from the limited options that we may have. So we have Dr. Jayanthan talking to us on keratometry pearls. Sayan Das will talk to us on tomography pearls. We have Dr. Arul Moli Varman, who basically uses IOL Master 700, but will be telling us about the pearls related to ultrasound biometry. Then we'll move on to optical biometry pearls by Dr. Anurag Mishra. We'll not be talking about how to do the test, but what are the do's and what are the don'ts and how do we optimize results with these technology. And I would also again refer to these guest editorials which were published over the last couple of years, and they gave a very good perspective of the formulas. What we learned that after the first theoretical formula that was published way back in 53 years back by Fyodorov, there has been a series of formulas that have come up, and then we classify them chronologically. This is a mixed bag. Most of the time this classification doesn't make much sense. So today the tendency is to classify the formulas based on the method of calculating the IOL power and the data that they use for these calculations. Vergence formulas have become very popular. Artificial intelligence formula, the Hill RBF definitely is making waves, and we are going to have the version 3 released in a couple of weeks' time. The ray tracing formula, though many of us don't use it, the Oculus are the Phaco optics because maybe they're the paid formulas. So, but we are told that they are the future of IOL formulas. Now, there's one enigma here. Now, our generation has grown up using Holiday 1, Hoffa Q, SRKT, Higis, and then came Barrett, Universal 2, Hill RBF. And we are told that, the last two formulas should be enough for most of our purposes. We don't have to use multiple formulas. But if you see the recent literature, last 3 or 4 years, there has been multiple new formulas that have come up. As you see here in this chart, there is the Kane formula, EVO formula, Panacea, Pearl DGHS, Nazer, T2, and many of these formulas have been doing extremely well if you go by the publication, the reports published in the literature in the last couple of years. So we definitely like to have some clarity on this from Dr. Hanbor Pham, formula overview, and he's going to take us through and suggest to us what exactly is the formula that we should be using. Then we'll move on to the Masterclass by Dr. Dr.Arup. As Dr. Mahipal has already mentioned, that he is a renaissance man in this particular field. I have listened to his talks when he delivered the Jackson Memorial Lecture, the American Academy, and multiple named lectures. And he has really revolutionized the way we think about IOL calculations, particularly toric IOLs. And we are very, very eager to listen to you, Doug, in your presentation. And we also now feel that, the formulas have come up pretty well. The biometric results are becoming more accurate. So the industry also has to keep pace with us and move along. So we need to have a situation where perhaps Ramesh will throw more light on this. Instead of having a lens available from steps in parts of 0.5 steps, we need to have 0.25 steps. The industry also needs to look into the IOL manufacturing tolerance. So Ramesh will be telling us about IOL power steps, the concepts of ELP, how important it is, and the manufacturing tolerance. And then we'll talk about the lens constants. See, even if you use the most sophisticated equipment and the best formula, if your lens constants are not properly done, you lose the game. Your results are going to be very, very inaccurate. And the importance of examination length also has been driven home. We have realized that if you have the lane length of more than 4 meters, it is okay. Anything less than that, you have to use a particular formula to find out the spherical equivalent refraction for the patient. And we'll have none other than Dr. Girish Jetwa talking to us about A constant optimization. So with these words, I wrap up my presentation, and then I would request Dr. Marjan Farid to get going with a talk on ocular surface disease and cataract surgery. Over to you, Marjan.